Good morning, everyone. Welcome to heaven. So it's my great pleasure to be speaking at the 14th Brain Injury Conference here at Scripps. And I'm extremely grateful to Dr. Lobatz, who I've known for several years, for inviting me to give the talk today. So let me get started. So I'm the medical director of Kaizen Brain Center, which is a private concierge-based clinical practice in San Diego. So we call it as a private clinic, but with the heart of academia. So today my talk is, and I have no disclosures. So the talk today is about using a form of treatment called transcranial magnetic stimulation in TBI and post-concussive syndrome. So this treatment has gained a lot of attention recently because of its use in depression. But the purpose of today's talk is largely focused on post-concussive syndrome. So this is the agenda for today's talk. So I'll give you a brief overview about TBI and TMS, which is transcranial magnetic stimulation. So you'll find me using the word TMS more often than the whole word. I'll give you some evidence of use of TMS in post-concussive syndrome. Then I will talk to you about some protocols, old and the new protocol that we developed at Kaizen. Then I'll give you some data, some interesting data from our clinic that we've treated for the past 2 years. Then I'm going to take you to the future. This is the preview of how TMS is going to transition into, through the world of neural brain mapping. I'll end by talking about the new protocol, which is the individualized patient treatment protocol that we developed at Kaizen. So TBI, what is TBI? So TBI is a neurological event that results in loss of consciousness, alteration of consciousness, and post-traumatic amnesia. Depending on the duration of these events and the presence or absence of brain hemorrhage, we divide this into mild, moderate, and severe. Mild TBI is the most common form of TBI and is accompanied by absence of any hemorrhage. And this is what we see most of the time in our clinical practice. The word mild TBI is the same as concussion. They have been used interchangeably. So what are the symptoms of mild TBI? Generally, when you have a concussion or head injury today, you feel you have dizzy spells, you have visual problems, and usually these resolve within 10 days. About 30 to 40% of the people don't have improvement in the symptoms and go on to have what is called as a post-concussive syndrome. The important thing to note here is that the initial neurological event has now transitioned into a neuropsychiatric syndrome. As you can see, there is more depression, anxiety, mood dysregulation, headaches, migraines, mental fatigue, brain fog that people complain. Now, this is a syndrome. Now, again, it can last anywhere from 1 month to almost 6 months. Some people have this syndrome for more than 6 months. We call that as chronic. And there are some risk factors for that, like it depends on how many head injuries you had in the past, or whether or not you had depression, anxiety, or other neuropsychiatric conditions. So, many years after you have TBI, then you're at risk for developing what is called as neurodegenerative disorders. Now, these are, NDD as we call it, is not TBI, it's not post-concussive syndrome, but rather progressive disorders. It could be Alzheimer's, it could be chronic traumatic encephalopathy, which is CTE, or they could have motor dysfunction like ALS or Parkinson's. Now, we really don't understand who go on to have what, but we do certainly know that CTE is more common among professional football players who've had repetitive TBI. And we also have begun to understand that there are some genes that play a crucial role. For example, ApoE4 has been implicated in Alzheimer's. And there's data that suggests that when you have ApoE4 and TBI, your risk goes a little higher than the general population. CTE, most recently, there was an interesting gene that was brought to surface, which is TREM106B at Boston University. So we are beginning to understand some of the genetic factors here. So now what is TMS, transcranial magnetic stimulation? As you can see in the picture, what you see are our texts. These are not our patients. I think they're smiling a bit too much here. So TMS is FDA-approved treatment for depression since 2008. It's also approved for migraine since 2004, but on a different device. So what we do is as you can see that magnetic coil there on the picture on the right, we take that magnetic coil and we place it over the front of your scalp on the left side. And that is the depression area. The underlying brain is the depression area, which is called as the left DLPFC, dorsolateral prefrontal cortex. And we stimulate that area with about 3,000 pulses. We do this in a span of 20 minutes, daily, 5 days a week, 4 to 6 weeks, until your depression gets better. Now, it's pretty well tolerated. There's very minimal side effects with some transient headaches that gets better. People drive in and drive out. It doesn't affect driving. And literally, I mean, we haven't seen any serious side effects besides these at all. The science is that on the left, you can see that with the magnetic field, what happens is it creates an electrical activity, particularly in the neurons of your brain, thereby improving the neuronal connectivity. This is really good science. It's been validated for several decades. Now we begin to understand that this science could apply to other conditions as well. There's interesting research being done in post-stroke rehabilitation, Alzheimer's disease, autism, particularly in social cognition. So I'll keep coming to this TMS again. So now, what's the evidence? So I'll briefly go over this. So Ross Zafonte at Harvard Spalding talked about how TMS could improve cortical hyperexcitability that happens after TBI because of the glutamate surge. And he also actually talked about how when you pair TMS with behavioral or cognitive training, it can cause rewiring of your brain, which we call as neuroplasticity. Samuel Shin at Hopkins talked about how TMS can balance the interhemispheric the imbalance that happens after TBI. And Lisa Koski at McGill did a preliminary study looking at the feasibility of using TMS and showed improvement in the PCS symptoms. PCS is post-concussive syndrome. And Albert Lewing at UCSD VA showed how it could be used in post-traumatic headaches. So there is evidence out there. Now, so in this slide, I'm going to talk to you about the traditional protocols that we use for treating depression with TMS. Now, as I said, it's FDA approved for a long time, and everybody treats it. And I'll tell you, this is the most common method that's used here. So, as I mentioned, the target in depression is 1, which is the left DLPFC, which is the area here. And how we get to that area through a rule called 5 centimeter rule. I'll walk you through how we get to that area now. So, as you see in the right side of the brain, on the brain map, there's a thing called motor cortex, which is the area right here. This area controls the movements of our hands or legs. Now, we give single magnetic pulses to certain areas in that motor cortex to understand what is the thumb area, what is the area that will make your thumb move. Once we hunt for that area and find out that area, then we measure 5 centimeters forward to that area, and we mark that area, and that is our DLPFC. So that's how we get to that area. And that's the area where we give all those 3,000 pulses in about 20 minutes, and we try to stimulate that hypoactive area which has been correlated with depression. Okay? So the previous slide was the typical area where we do treat depression, and this is commonly used. This is the current method that is used widely. However, when your depression comes with TBI, now we're talking about different things. Now, as a neuropsychiatrist, we understand that TBI is a circuit disorder. It just doesn't involve one area. The reason is this. When you have depression in the spectrum of post-concussive syndrome, but remember, it's not isolated depression. It is accompanied by mood dysregulation, emotional dysregulation, cognitive difficulties, and whole other symptoms. So this indicates that it works in a circuit rather than being a single isolated area. So in depression with TBI, there is multiple targets, whereas in depression without TBI, there's only one target. Now, how do we get to this multiple targets in depression with TBI? So that's when we developed this Kaizen protocol in 2016, when we started. So we used clinical evaluation to understand what those targets are. We used an interdisciplinary approach with neuropsychiatry, neurology, neuropsychology, and advanced diagnostics, including MRIs, both structural and functional. Once we understood what circuits were involved, then we used a very sophisticated system, neuronavigation system, to go to that target. So, in this slide, I'll talk to you about what is neuronavigation system. So, in the previous slide for depression, I showed you how I can use the 5 centimeter rule and go forward, and I can get to the depression area. What if your target is parietal lobe or temporal lobe? How do you do that? That's when neuronavigation comes into place. This is the same system that neurosurgeons use to do surgery. It has a stereotactic approach. So what do we do? So first we get a structural MRI, and then we do a 3D reconstruction of the brain using a specialized software. And then on the first day when the patient comes for TMS, he's sitting on this fancy blue chair that I showed in the picture. Then we put a probe over the scalp area, and there are some small sensors. And in front of him is the optical camera that senses the sensors and understands the positioning of the head, and thereby the underlying brain area. And then the structural MRI that we reconstructed is on the screen, and voila, everything is relayed on this MRI. And I can move my magnetic coil virtually and go to the target location that I identified through my clinical evaluation. So this is what is neuronavigation. Think about this like a GPS for your brain. So if you use your clinical evaluation to understand where your location are, and use the neuronavigation to get to that location. So Kaizen means constant learning. And one of the most important people who teach us are our patients. I learned everything, a lot of things that I know today about TBI, I learned it from the veterans. I think there are a lot of unknowns in TBI than knowns. So we should always be open to learning from our patients, because every head injury is different. Sorry. Okay. So one way to advance this field is sharing data. So that's exactly what we did. So ever since we started, we presented our data at the Boston University CT conference, where we go yearly. And we presented in 2017 and 2018 last year. Okay, so this slide is from our poster. As you can see, this is the measure of depression and anxiety. Depression is measured using a scale called PHQ-9, which is a patient questionnaire, has 9 points, and anxiety is measured through GAD-7. As you can see on the slide, the x-axis is the duration of treatment, and the y-axis is the score of depression. Highest score means bad depression and anxiety. Sorry, you're having some technical glitch here. So as you can see, and the lines are of individual patients. As you can see, there is a steep decline in this course, indicating improvement in anxiety and depression. Now, I'd like to highlight here is that these are the patients who have actually failed psychopharmacology. These are severe PCS who are treatment resistant. So there's some signal in that data there. So now I'm going to transition quickly to some of the interesting patients that we've seen. So this slide is from our 61-year-old female who came all the way from Texas. She had mild TBI, but a very severe comorbid history. She had upper motor neuron lesion. She had difficulty with speech, dysarthria, and gait issues. She was already diagnosed with pseudobulbar affect at Banner Neurology, where she was treated first. So she had lots of mood and emotional dysregulation, which was not adequately controlled on Dexter. Cognition was intact. So we used a bilateral TMS protocol, which means we stimulated the left side of the frontal lobe and we inhibited the right side. And we, again, measured the anxiety and depression. As you can see, the blue and the green are the depression scales. The blue is the PHQ-9 and the green is the HAM-D. PHQ-9 is a smaller scale and HAM-D is a bigger scale, and the purple is a GAT-7, measures anxiety. Again, you can see a steep decline in the scores, indicating improvement in both anxiety and depression. But the most important thing was this. So when she got the completed treatment, went back to Texas. I remember a few weeks after she went back to Texas, I got a call from her primary care physician telling not to stop what we were doing. He really didn't understand what we were doing, but he said, whatever you're doing, don't stop. Then we got a call from the physical therapist who works very closely with her, and he said her movements are very fluid. Then we got a call from speech therapist, and she said that she speaks with less effort. I mean, suddenly overnight we became heroes. So this is her. So on the left side is a small clip that her daughter took after 2 weeks of treatment. And on the right side is when she completed the whole course and came back to us for a follow-up visit and wanted to surprise us. So let's see if it works. There you go. So she threw a towel. I remember the daughter texting me and saying, Dr. Ahmed, for the first time in years, my mom threw a towel. And she's sitting in the wheelchair there. On the right side is when she came back from a follow-up visit and she wanted to surprise us by walking in without a wheelchair. Okay, there you go. She's walking in.
That's amazing. That's so amazing.
And that's hugging us. Let me talk to you about her. The other, besides improvement in depression and anxiety, I think there was a functional improvement, as we saw. Again, I think, this is a rehab conference. I've worked in inpatient neuro rehab during my fellowship. Getting patients to be motivated to do rehab is a big thing. I think, what really happened was the TMS motivated her to go back to rehab, and probably that improved her physical outcomes. So this is another patient of ours who had okay, great. Now, who was a Navy pilot with moderate TBI. Now, moderate because he had lesions on his brain. There were old microbleeds on the right parietal lobe. So he had post-concussive syndrome. He has apathetic depression, anxiety, but more predominantly cognitive issues. He had memory issues, visual-spatial difficulties, which was affecting his sailing. That was what he does. Also was getting more impulsive, getting into alcohol addiction, and also was having migraine headaches. So again, we used the bilateral TMS stimulation, left stimulation, right inhibition, and those are his scores. You can see improvement in anxiety and depression. Interestingly, if you note, the depression, when we measured using PHQ-9, didn't get so better, but when we measured using HAM-D, there was an improvement. HAM-D is a much larger scale, about 21 questions, versus PHQ-9 is only about 9 questions. So clearly there was an improvement in mood and anxiety. More importantly, there was a cognitive improvement. He went back to sailing and didn't have the visual-spatial difficulties. He took a complex physics class and did really well. And his alcohol craving also decreased. So did the intake. So there was a functional improvement. Now, this is another moderate TBI, a 47-year-old Olympic champion who had a TBI from falling from a high bar, had a subdural as a result of that, had largely apathetic depression and migraines. So here we stimulated only the left side. And what you see on the right is the data. So she had complete remission of her depression and anxiety. Look at the scores where it came down. And more importantly, she had functional improvement. The depression, apathy was making her go away from the practice, and she now could go back to practice and get back to function, her baseline function. That was huge for her. And also, she improved with her migraine significantly. Now, this is a 41-year-old male. Very interesting. He was referred to me by his primary neurologist just for TMS, for post-concussive syndrome. This was what happened. So he travels a lot, trains a lot of executives around. So he was traveling around a jungle in South America when he was in a truck with a lot of people, and I think the truck hit a boulder, and he went vertically upward and hit the hard surface of the truck, so straight up. His presentation was slightly unique. He had perceptual difficulties, depersonalization. He could not sit still, restless. He couldn't go on a date. So he would be walking around the date, and it was very awkward for him. And it was affecting his social life too. So he traveled, so he went to Europe. He saw some specialists. He didn't get a good answer. He went to Mayo Clinic. Mayo diagnosed him with post-concussive perceptual disorder and did the neuropsych testing. He had problem with visual drawing of the clock. He couldn't draw the clock. I mean, this is a high-functioning 41-year-old male. So now this indicates a parietal injury. Now, we did a neuroimaging volumetric, and we really didn't see any volume loss in the parietal lobe, but nevertheless, we went ahead with the TM treatment, and that's what you see, his complete significant improvement in his anxiety and depression. More importantly, functional improvement. He was less restless and able to go back to date. He improved with his migraines. And also, you can see he drew the clock now. That indicates some degree of a recovery with his visuospatial deficits. So this was a huge change. Now, this is a 28-year-old female. She came all the way from down under. Olympic champion, had a severe TBI, moderate TBI. She had, again, very classic symptoms, apathetic depression, but something else. She also had a lot of oculomotor dysfunction, motor incoordination. For the sport she does, she was not able to coordinate well. Now, we measured that using this device called iSync. This is virtual reality goggles that you put on. It came out of Stanford. It's FDA approved for diagnosing acute concussion. And what you do is there's a red dot, and you look at the red dot, and you follow the dot. Normally, in people without concussion, you can follow. There's a sync. But in concussion, what happens is your eye jumps ahead of the red dot. And that's what you measure, and you can diagnose the oculomotor dysfunction on that. She had that. So we, again, used a bilateral protocol. As you can see, there was an improvement in anxiety and depression. More important improvement was, I think what we understood, what we found out was the anxiety, the apathy, the emotional roller coaster was taking her away from the practice. And also, the lack of oculomotor coordination was, just keeping her away from practice. And once everything got corrected, she went back to practice, and voila, everything changed. So we just broke the cycle. So that was a significant improvement. Her migraines also significantly improved in this case. So now, the next two cases is the essence why I started Kaizen 2 years ago. As Dr. Lobas mentioned, I trained in TBI, I trained in memory disorders. And my academic interest is to connect them together, to understand how TBI causes Alzheimer's or CTE. And 2016, I did some work at UCSD. We wrote a paper looking at the correlation between TBI and Alzheimer's, and we found a positive signal. And that's exactly when I decided to start Kaizen. So Kaizen was not started on a business model, but on a scientific model. And March 17th will be actually 2 years. So we did something right in the past 2 years. So this in the next case talks about this correlation. So now this is a 46-year-old female, again, referred to us by his neurologist, had a moderate TBI from a volleyball. Besides had significant progressive memory decline, short-term memory, repeating questions. Husband was really concerned, and also had migraines and oculomotor dysfunction as we measured with iSync. She had microbleeds indicating the moderate TBI, but interestingly, we found that there was a severe generalized atrophy for her age, that was above her age. And we also found some asymmetric atrophy in the temporoparietal area, very small, but it was starting to happen. And that coincided with our neuropsych testing. So now we had to change the protocol. Now imagine, now we're not only just treating the post-concussive syndrome, but also trying to look way ahead of how we could prevent the trigger of neurodegenerative process. Now we not only stimulated the frontal lobes, but also the temporal and the parietal lobes. So that's her data. So you see she improved with her anxiety and depression. More importantly, she improved with her cognition. We measured, there was a 2-point improvement in her MoCA, in the memory scale, and there was also an improvement in the verbal memory, and as we measured using another validated scale called R-bands. So other important thing is subjectively her memory got better. Her husband gave us the collateral information, and he was very pleased with the way she is improved. So the other important thing that we did is that we actually paired the brain stimulation with cognitive training based on her neuropsych deficits. Remember the paper by Ross, how he said that when you combine brain training with TMS, you can rewire the circuitry. I think that's the science here that we used. So now, this is my last case. So this is a first case of possible CTE. I use the word possible CTE because in my practice of 2 years, there are a handful of people, very few people I can count. I said this, I'm concerned for CTE, and he's one among them. He had a history of repetitive head injury as playing football. Again, a lot of post-concussive syndrome symptoms: apathy, impulsivity, short fuse, emotional lability, forgetfulness, suicidality. Didn't respond to any medications. I mean, lithium at the highest dose didn't work. Lamictal, Depakote, Nudexta, antipsychotics didn't work. I mean, paradoxical reactions to it. Again, we made sure we ruled out Alzheimer's. Of course, you can't diagnose CTE without ruling out Alzheimer's. And there was nothing, no hippocampal volume loss, no parietal lobe atrophy, DTO was normal, no KVM as well. And his MRI showed some hyperintensity too. So I consulted, he was my colleague at UCSD ruled out any MS. So it took me almost 8 months to come to the conclusion that this is not AD, this is no other neuropsych condition. It could potentially be CTE or TESS, the traumatic encephalopathy syndrome, which is the new research name. And then we started TMS on him. And that's the data you see. Significant improvement in depression and anxiety. Not only depression and anxiety, his neuropsychiatric symptoms improved, like the impulsivity, the disinhibition, the agitation, based on NPI, which is a validated scale. You see, pre-TMS he was 18, after TMS he was 4. And also the caregiver distress. His wife was very worried about him, and that improved by 50%. So, a couple of things I would like to state here. So the data that you see here has a very strong signal again. This happened without the help of any medications on somebody who was progressing so bad. The second thing is you have to also be careful how you interpret the data. By no means this TMS cured CTE. No, TMS just improves some of the symptoms of the condition. Third is you have to understand that CTE is not post-concussive syndrome, it's not concussion. Fourth, we have to pay attention to the caregivers. Remember, CTE or TBI does not affect a single individual, but the entire family. All right, now, that's all I have to talk about myself, nothing else. Now, the rest of the talks are on this amazing person. This is Dr. Shan Siddiqi. He's a neuropsychiatrist, Harvard-trained neuropsychiatrist, and a fellow of neuromodulation at Beth Israel in Boston. So Dr. Siddiqi, I met Dr. Siddiqi when I was at training at Boston, and his research focuses on understanding different circuits in depression with TBI and without TBI. He and I have initially started talking about how to do things, how to use that approach, and I invited him to Kaizen, and we showed what we do, and he was very impressed, and he became a collaborator, then a consultant, advisor, and above all, a very good friend. So we realized that we have a lot in common. And both of us were challenging the 5 centimeter rule. Now remember I showed you that slide where 5 centimeter rule for depression without TBI? Both of us were doing the same thing. And so this paper is his most recent work, amazing work, which is under review at Science. He showed how different circuits are involved in different symptoms of depression. And the co-authors of this paper are none other than Albert Pascal Leone and Mike Fox at Boston and Mark George from South Carolina. These are the pioneers of TMS. I mean, the reason why we do TMS is absolutely because of these people. So, some of Shan's work. So, this is his work, and he's given me permission to share his data. So what they did was, I think this paper will fundamentally change how we do TMS in the future. So what they did was they collected the TMS target sites from Harvard, from South Carolina, and from Michigan. And they understood the networks that those target sites were connected using a large connectome map that they already had at Harvard. And they made brain maps of all these patients from Boston, from Michigan, and from South Carolina. And then they found out that within people with depression, the maps were different. In people who had depression with sad symptoms and for people who had depression with anxiosomatic symptoms. As you can see on the right, the maps are quite different there. And in fact, to the point that when they plotted on this slide below, you see that actual target. So the target based on the 5 centimeter rule was up, and the actual target based on the neuronavigation guided TMS, which showed improvement in the symptoms, was away from the target. This paper validates our approach that we started 2 years ago. So this is a great joy for us to know that we were right. We were thinking right way ahead of time, and this paper essentially validates our approach. So the previous paper, I talked about how you can do generalized network mapping in people with depression with TBI. Now we're going to transition to how we can do this network-based mapping for people with depression without TBI. And then I'll transition you to how we can do individualized TMS based on specific person. So again, this is Dr. Siddiqui's work. It's published, this is a paper that it's a clinical trial that he did and published in Journal of Neurotrauma. So what he did was he had patients who had TBI with depression, and he did a resting state fMRI, and which means you stay in this MRI in a resting state, and we understand the flow of oxygen. We call this as the Bowl signal. And by doing this, he mapped the networks. He identified networks that were impaired, and those were the dorsal anterior networks and the default mode networks. And then what he did was he stimulated that with the same protocol. He stimulated with left stimulation and right inhibition. If you remember, this is the same protocol that we used in our patients. He used the same approach, and he measured the outcome of using MADRS, which is a depression scale. So he found that there was not only clinical but also statistical improvement in depression using this approach. So this is the first preliminary study that validates the use of TMS in post-concussive depression. Now we're going to talk about individual networks, how you can do this group-based targeting to individual targeting. This is again Dr. Siddiqui's work. It's accepted at the Journal of Neuropsychiatry and Clinical Science. So you have these 3 maps of brains. One, the top line is the single NFL player who had player with TBI. The second line is about controls. This is people who had 1 TBI with depression, and the last line is about healthy volunteers. So the NFL player had about 12 concussions and about 7,000 subconcussive hits, and was having progressive mood decline, anxiety, impulsivity, memory issues, both short and long term. And the second line is single TBI with depression. So again, they did the fMRI and just made the brain maps, and they found that the maps were different. You can see, as indicated, the blue are the light and the dark blue are the dorsal and ventral attention networks, which is quite different among different people. So again, he targeted the left and right stimulation with TMS, and he measured depression with MADRS. He found 72% improvement in the depression and measurable improvement in cognition and migraines. Now, this is the first time somebody has actually done this individual brain network mapping to target areas. So the question is, why do we do this? So because even though you do a group network analysis, there's a variability among the group and individual network locations in the brain. And remember, every TBI is different. So I think the future is individualized network mapping. So the other interesting thing that they found, which was there in the NFL player, not in the other control, was he found that there was a variability in the network that connects the medial temporal lobe to the default mode network. Medial temporal lobe is the area for memory that has been implicated in CTE, where the tau deposition happens. So it made quite sense that the NFL player had repetitive head injuries, so he's most likely at risk for tau-induced CTE. Now, so far I talked to you about how do we do it at a group level, how do we do it at an individual level. Now let me just give you the nuts and bolts of how it is done. So as I said, to do the brain maps, we first do the resting state fMRI. And then here's an example. So think about this, the yellow colors as brain circuits. The white circle is the area that we want to stimulate, that's the brain memory area that we want to stimulate, and it's too deep for TMS to go there. So what we do is we understand what is the area that it is connected on the surface. So the black circle now is the area that is superficially connected to the deeper area. That's the area where we do TMS, and that impulses go, travel all the way down. This is the same as Parkinson's. Now, Parkinson's, there's an area called the subthalamic nuclei, which is affected, which causes the motor dysfunction. And you do deep brain stimulation, which is an invasive way of modulating that area. There's interesting research being done at Boston right now using the same network maps to understand what is the area that deeper area is connected. It's usually in the supplemental motor cortex area. And what if we stimulate that area? Can we improve the motor dysfunction? So it's an ongoing research, but that's the same approach. So now how do we get those maps? So, of course, we get the MRIs, we send to Boston, we correlate that with clinical symptoms, we understand the circuits, and we get coordinates, numbers. You use that numbers and plug it into the neuro navigation system we have, and voila, we are in the right precise coordinate. So this is an example where, the dark purple area without the circle is the hippocampal area, and have the coordinates and how I can get to the area that the hippocampus area is connected to the cortex. And I can stimulate that area, and the impulses will be carried all the way down to the hippocampus. Now, so previously when we started in 2016, we had only comprehensive evaluation and neuronavigation. But now we have this individual neural circuit maps that we can use to essentially target more specifically. And this is our timeline. We started with challenging the 5 centimeter rule. We had the Kaizen approach, and then we had the individualized TMS. Think about it like this. If I had to do brain stimulation, first I had to do the whole Carlsbad area. Then we came up with the Kaizen protocol that only stimulates the western area. Then, with the newer technology, I can stimulate precisely this conference room, right this conference room. That's how precise I can get. So, I will wind up here. So this is something about Kaizen. But so TBI is a complex neuropsychiatric syndrome that affects distinct brain circuits, and comprehensive neuropsychiatric evaluation helps us understand those circuits translating into symptoms. This individualized brain mapping can map those circuits, and TMS can target those circuits. So the mission of Kaizen is to translate cutting-edge research into clinical solutions for our patient. And individualized TMS is one such example. Thank you. Okay. Yeah, so I'm ready for any few questions. Yes, please. I'm sorry, I can't, sorry, can.
These improvements in people's depression and anxiety, do you have any measurement of how long they last after the treatment, and do you have to repeat the treatment further down the line?
Yeah, exactly. So very good question. The question is, how long does the treatment effect last? And is there a way we do something about that? So we don't have good data to say how long this lasts. We have some data in people with depression without TBI. But with TBI, there's literally no data to back on. So what we have done is we do what is called as maintenance TMS. So depending on each individual patient and the severity of the symptoms, we get them back after 3 months and do a stimulation for a week. So we have started to collect long-term data, and as we speak, we are analyzing the data and we are writing a manuscript for that. But very good question. Yeah.
How long after the TBI is the TMS implemented? Is it, for your studies, was it a long period of time, a short period of time?
Yeah. So the patients I've shown had almost TBI almost at least 2 to 3 years prior. But there's some interesting research being done to implement TMS way early. So, when you have the initial, when you have a concussion, what happens is that there's a glutamate surge, and there's a hyperexcitability and the interhemispheric imbalance. So it's reasonable to start early. And if you ask me personally, I think the earlier the better. Yeah.
Are there any NIH-funded clinical trials that are going to be using TMS and TBI-related?
Yeah. So Dr. Sarah Listenby is at NIH. I just met her a week ago, and they are planning to start a new clinical trial through the NIH. Hopefully, it should be in the next few months. Oh, yeah, please.
Some depression.
So the question is there any evidence of use of TMS in chronic pain? Correct. So there is evidence of using TMS in chronic neuropathic pain. Yeah, there is. I will give you more data on that. If you please ask me the question once I step out. But yes, there is evidence. There is no clinical trials. It's all anecdotal evidence. But I've shared my colleagues at Boston. They do treat chronic pain that is neuropathic. You're welcome. Thank you once again.